So welcome to you again, my beloved colleagues, those who are preparing for the PACES. And I can recall that in the last few sessions also many of you attended, and I believe that it was fruitful, but I couldn't claim that it was maximally fruitful to you. As a human being, I might have some limitations as well, but from my heart, I'm trying my best to make you understand. Those who passed part 2 recently, they are very fresh, and very A, B, C, D should be known to each and every candidate, those who are appearing for the PACES. For that, I thought that better to start from the A, B, C, D. So with this thought, we are progressing and we are trying our candidates step by step up. So this is the institute welcoming you today as before. And first of all, just to remind you that this is the PACES carousel. And every time you have to remember it. You see the station 1, 2, 3. You have seen before. We had a basic overall discussion class also before. So, but the history in the station 4 is a communication. We are discussing about the station 5. It is divided into two parts, 1 and 2. You know it. 10 minutes time. So how to manage the time and everything, I will discuss in the later part of my discussion. The whole carousel will take 125 minutes. This is the current strategy of PACES exam. So look at one sample of instruction given here. Just you see that station 5, brief clinical consultation. The name of the station is brief clinical consultation. So it is a very taller page. I actually made it small one for you, easy visibility. Just have a look that there are many parts. In these many parts, few parts are very common for each station. So from the very beginning, as a strategy, if we come to know what are the fixed informations in the preparation time, in the 5 minutes waiting time, it will not waste our more time. The referral text is important, and your patient detail and your role will be different. Others are okay. So I'm jumping to that part. You see, I just cut it into three parts. The three parts are very common. So let's go for understanding this common information for you. I'm sorry those who know about this from early, from beforehand, but I told everybody and we have given the notice also that this session for the very beginners. So those who are with me, I will not mind, but you can learn also even as I tell something extra beneficial for you. So you see that this is that one, 10 minutes time. After 6 minutes, you will be alerted. It is told that 2 minutes left. And at the end of 8 minutes, time up, immediately examiner will ask. So this time setting is how much narrowed. Only very little time. In this time, you have to organize everything. So what we discussed on off the record before starting the real session with Dr. Madiha, that is very short time. So no need to make the situation very critical. Station 5 is not much critical, but thing is that to get the hints given there, if we are oriented from before of similar hints, so it will not take more time to go into the main agenda. So this is very small time, and examiner will only take 2 minutes. So there will be strategy of asking question also. And we discussed in the history station, examiner will take 5 minutes time to discuss in the history station, in the communication, and in the clinical examination station. But in the station 5, only 2 minutes to the examiner. So examiner, how much he will ask? The basic question will be there, but in between some contemporary question there to ask. So question will be very small, answer should be also small. This is the strategy. Now what could be your task for each and every station? It is actually given by the Royal College. You already have seen. We couldn't compose it. This is the Royal College prototype example of a sample informations. So you assess the problem by means of brief focused clinical history. So this is the new word here we have to learn about or be conversant about the focused clinical history and the focused examination as well. So we come across before detailed history taking and the examination procedures in the cardiology, respirology, anywhere. In this session 5, how to make the focus history and the focused examination plan. Again, like Dr. Madiha, anybody asked me that, is there any book can have the prototype focus history and examination is there? I like to say no. Again, it is a matter of understanding. It match with real-time activities as a professional in the chamber. We are seeing our patient in our chamber or surgery, whatever we say, around 10 to 15 minutes we are giving to the patient. So in the examination, the 10 minutes set for this understanding to match the exam as a real life event. For that, within short time, why should we take history? If you can recall my previous talk, this is for the diagnosis, to exclude differential diagnosis, to identify comorbidities, to identify etiology, to identify functional status of the organ affected, even the for research purpose also we are asking. But in the PACES examination, the research purpose is not much important. But what I told about 4-5 aims, these are very important. The same aim also implemented in the examination and even the investigation target. So in the focused history, how much we can identify 4-5 things, but first thing will be diagnosis in the station 5. Etiology clue may be there in the history. In the examination, better to identify the complication. But in the talk, if we go inside much more and more, major or minor complications, we will waste our time. I told you before also in the last part of my talk today, I will try to show you how to manage the time in station 5. So focus history with a little one case. With the case, I will try to describe you a little later. So you do not need to complete the history before carrying out an appropriate examination. Uh, so I think you have, if you have gone through, it is easier for you. Just I'm reading for those who are very, very new today. History, usually the fixed sequence is history followed by examination. But here it is not important though. We start with the history, we will take the examination, we'll go for the examination, and again we can come back to the history taking. It is acceptable and it is very practical as well. Advise the patient of your probable diagnosis in the patient understanding definitely in the layman term, and your plan for investigation and the treatment where applicable. Respond directly to specific any questions concern of the patient. So these are very common information. You will be given a paper with a pen or pencil. You may use your pen, but if you enter into the chamber in practice, so far I can remember also, the experience is that in the station 5, this writing as like history taking station and the communication is not practical, because you are facing two stations together. You are given 5 minutes time. After the 5 minutes, you enter one station 5 and 10 minutes gone, you came out and again entered into the second station in the station 5. So there is no time to think about that, which case I have gone through in the station. Suppose if it is made as station 5A, station 5B. So which one in the station 5A and which one in the station 5B also may be impractical there. But just have a look, 5 minutes, you can think together about two patients. Whenever you enter, okay, may I know good name or good evening, good morning. Asking by name also, you may forget. In the station 5 it may happen, but it is customary that in the case 1 the examiner will guide you to enter the case 1 first. So minimum try to remember the name of the patient of case 1, but it may happen in practice. For the case 2, you may forget the name of the patient. It is very practical because you were busy, you were sweating in the station 1, the case 1 in the station 5. So no need. But I told you before, in the history taking and the communication, forgetting the name is not good in the station history and the communication. But in the station 5, examiner will not mind, especially you forget the name of the second patient, because they know that you just came out from the case 1 and immediately enter into the case 2. So in that case, how to proceed on? This is a matter of technique. Okay, I think I may not tell about detail that. Just I'm telling the practical situation which may happen in the station 5. So the paper, just you can keep it in your hand. My advice will be that minimum write the patient's name and age and the presenting complaint. No need to write further, because if you write one patient detailed information, then detailed information is usually not given as well. I will show you, already have shown to you. So these are the common things, this one for each and every station. Now come to the main agenda of your performance. This is the patient details, Mr. Joe Brown. So this is two parts. I am now enlarging in the subsequent slide. Can be good visible for you. This is a male patient, 22-year young. You're the doctor in the medical admission unit. Always I emphasized it. Those who attended my last classes, you understood that. I told about this also. You are working where? This is important for your management plan. And what is your identity? This is also important. So you are the doctor in the medical admission unit. So today your ward is designed for admission of the patient. What is the problem? The man presented to the medical admission unit with a sudden onset of severe headache. So in the history taking, if you can remember or you go through some cases, only it is said that patient suffering from headache for last 1 month. Up to these, no other characteristics of the headache usually in the history station. But here in the station 5, sudden, right, onset of severe headache. So in the young patient, sudden severe headache, there are some possibilities. But in the elderly male patient, sudden severe headache, there may be some other possibilities. So from the very beginning, you can divide the patient into two groups, young and older groups. So in the young patient, it could be sudden, duration is not given. Very, very interestingly, you can see if it is very 1 or 2 days, or it may be of 1 or 2 hours. So many of you know that as you passed your part 2 exam, very sudden severe headache of hours. Hours means is a vascular phenomenon. I talked about this in my other classes, that focusing, how to focus the focal lesion, how to identify the focal lesion, already given in the YouTube also. Many of you have seen it. Identification of the lesion, right? Localizing sign, how to identify localizing sign. So this is also symptom. If it is a vascular one, it is of hours. So definitely you will ask this thing. We have designed an history taking sheet, and there are some qualities are given. I will show you a little now, that if for any symptom, though I discussed it before, what qualities should be known. From these qualities, some qualities already told here, the severity already told, and the onset already told that it's very sudden. Okay, these are the basic vitals, blood pressure, and it in each and every station. Be attentive to these. You don't think that all are always will be normal. There should be some abnormal data, otherwise why will they give it? Maybe febrile patient, maybe hypertensive patient, and other. So you see that respiratory rate 18, pulse 86, systolic 114, diastolic 76, saturation 98, temperature 36.5, other data not given. So it is almost normal data. So now the history is the very, very important thing, and you can proceed forward. So today is not the practice session about that. I am thinking that it could be subarachnoid hemorrhage case. Possibility is there. As Dr. Madiha asked that, how can we design? So first of all, you think, okay, subarachnoid hemorrhage, but it may be other thing also. There may be some comorbidities also. So how to ask further question? This is your strategy. So now proceed on that, the further questioning. But before that, how examiner prepare themselves to to take the exam from you. It is called calibration. In each and every station, examiner went a session before starting the exam. It is called calibration. There is a sheet. In the calibration, for each scale, examiner should write that in which informations they are actually making a consensus. That if you ask something, patient will answer something. If you give a plan of investigation, both examiner will be agreed upon. So they have to write that the investigation plan of the patient should be as such. Examination plan should be as such. There is splenomegaly, there is hepatomegaly, there is anemia. So you should not be worried. Sometime in our life, in our learning session also, your colleague is confused that this is anemic or not. But you are telling that patient is anemic. Think that in MRCP, this type of opinion should not be there, usually not be there. Because if the patient is anemic, both of the examiner will agree upon that there is anemia. So definitely, as a doctor, as a third person, you can identify that patient is anemic. Everywhere, not in the station 5, in the clinical examination station also. If they are plantar extensor in the neurology, definitely there should be plantar extensor. Examiner also will not be confused. So if two persons are not confused in one finding, third doctor usually will not be confused. But if third doctor like you have some lacking of understanding, you may be wrong, this is your discredit. So for that, they made a calibration sheet for each and every station. So I think you have already collected such paper. Uh, Otherwise, you can discuss here also. I am now a little showing with an expanded form. What key elements of history must a satisfactory candidate cover? This is one point. Second point, key components of physical examination should a satisfactory candidate undertake. That means which examination should be done, not all together. Suppose headache is given, it doesn't mean that you will go for all full neurologic examination. Full neurologic, what does it mean? Lower limb, upper limb, cranial nerve, higher cerebral function, including fundoscopy and any other. But from the list of the neurology, you have to identify which finding can give me some information for the diagnostic purpose or for etiologic identification also. So in the very short time, we cannot discuss this case. It may be critical for you from the very beginning. Have a flavor of how to prepare yourself. Only for the discussion today, we said today. What key steps in the management should a satisfactory candidate consider? That means the headline of the management plan, not the detail. They will ask, how will you manage this case? Not that I will do this one after another. Then if you find that no, just tell the basic principle of the management. Remember that the last 2 minutes only having to discuss many things with you. How should a satisfactory candidate respond to the patient's concern? In each station, other than the examination 1 and 3, everywhere you have to address the concern of the patient. It is very important. What physical signs you have to identify? This is there. There is a clubbing, definitely clubbing. You should not be confused that it is early clubbing, late clubbing. Many types of people are telling many types, but it is not practical one. Clubbing is there. You definitely will get that. There are basic 3 findings of the clubbing. So minimum you can get 1 finding of the clubbing. Yeah, nail the angle issue, then Shamroth sign, fluctuation test, whatever you say. So next point, what differential diagnosis? Okay, what diagnosis should a satisfactory candidate consider? This is that point, but there is no point for the differential diagnosis, maybe or may not, somewhere. Managing concern, you see that, is there any separate differential diagnosis? This one, headline is there. But what diagnosis should a satisfactory candidate consider? That means diagnosis and differential diagnosis all together in the one scale. Not that you identified one diagnosis, this is one scale. All together, not separate one. So this is differential diagnosis or diagnostic capability, whatever we say. From there, in the station 5, to pinpoint a diagnosis is easier. This is the basic philosophy. And lastly, the managing patient welfare. In each and every station, it is important. So these are the 7 skills, and these informations are not very new today, though I tried to explain it to you. And this is the examiner sheet you have to fill up in the earlier. your name and other roll numbers and other everything. This is that information, satisfactory and unsatisfactory. I touched this information before. What will be the satisfactory informations or skill in the uh, history or communication and other. Today, as the station 5, I think we have to expand it, the discussion, because today will be the last day of such discussion. And you see that, sorry, give me a little time. There is some technical problem. Sorry, Dr. Islam, can you help me? Can you hear Dr. Adnan? Dr. Adnan, can you hear me?
Yes, sir.
A technical problem I face suddenly. Okay, we can carry on. Don't mind. So what I like to discuss it that clinical skill, these are the satisfactory issue. So possibly you have gone through in the previous session also. I am requesting all of you, if you can read here, please read by yourself and ask me what you don't understand from any point from here. Better, may I request someone to read the first one, satisfactory. Dr. Adnan, can you talk this loudly? Dr. Adnan, please read for everyone. Everybody can share because this is the main idea. Because in the PACES exam, examiners are testing your skill, not the diagnosis, not the station. So for each and every skill, what your satisfactory qualities, what are not satisfactory qualities, we must know about that. Dr. Adnan, please, if you can read speedily also. Can you read it?
Elect history relevant to the
Yes.
elect history relevant to the compliance and explain informations to the patients in a focus, fluent, professional manner.
Okay. Do you have any confusion, Dr. Adnan, in this box?
Nothing more.
Okay, good. If any
Nothing more,
candidate,
sir.
please, if you are confused, you can ask me. Thank you very much. So, who will read the second point, please, other than Dr. Adnan? Anybody interested? Dr. Adnan, please, can you continue? They are rather to hear more.
Physical examination, correct, appropriate, practiced, and professional.
Practiced, professional. So, examination should be professional one. That means there should be a system. Correctness should be there. It should be appropriate. Practiced. It is very important. You know a lot, but you are not practicing your examination skill. You cannot produce in the examination station. Okay, good. Who are ready here again? Who previously attended? Dr. Islam is there today. I'm sorry, I cannot get him. I think Dr. Adnan can continue, but we find some noise of you also. Sorry, Dr. Adnan, I'm sorry, having some noise, so I can read for other also. Thank you, Dr. Adnan. So you see that in the station 3.1, select the that means third skill, select sensible and appropriate investigations and the treatment. Sensible, appropriate investigation. This is the important thing to learn about. Patient concern, always in each station, detects, acknowledge, and attempts to address patient's concern, listens, empathic, listen. And those who have gone through my article on this communication skill, they know what is the listening means. Already video also uploaded in the YouTube. Listening means active listening, not the passive listening. You will encourage the patient to talk more. You will guide the patient. Patient may tell you a very irrelevant thing also. This is part of the listening skill. Identifying physical signs, you know about that. Do not find signs that are not present. Very important. Suppose clubbing is not there, you are confused also, better not to tell. It is differential diagnosis, already we discussed, we have told you before, including the correct diagnosis. Sensible differential including the correct diagnosis is important. Why important? You understand that if your diagnosis is wrong, the next investigation planning will be wrong, next management plan also will be wrong, so you are not getting the marks further. For that, diagnosis should be clear, but one thing is that diagnosis should not be that one, your probable diagnosis, what examiner also thinking. But suddenly, if you may not identify the number one diagnosis, minimum, the correct diagnosis should be in the differentials. Otherwise, examiner cannot guide you. So take care about correct diagnosis to do the correct diagnosis. Maintaining patient welfare not only by the physically, it should be in the mentally. We should not jeopardize the mind of the patient. So these are the satisfactory thing. In the last column given the non-unsatisfactory thing. So omits important areas of the history, should not omit important area. So which will be the important area? This is a matter of learning, right? Few months you will be busy in your planning, then you will be, I hope that you will be much competent to identify which important history informations in the history is very reliable one or related with the patient. So again, unpracticed history taking, unprofessional, poor explanation to the patient. So we have to practice that, how to explain the disease and the management plan to the patient. There they will judge you that are you using layman term or you are using the jargon, are you telling irrelevant thing or less relevant thing within very short time, the examiner will judge you. So just I am rapidly now going down. If you have any query, you just stop me, I will explain. Incorrect techniques of physical examination, omit significant or important tests, inappropriate focus to examination, hesitant and lacking in confidence, unprofessional again. Hesitant means one after another, you are looking at the anemia, then clubbing, coming to the pulse and the blood pressure, but you are hesitating one after another. You have done one thing, 1 second you are thinking, okay, what I have to do next. This is called hesitation. It is very, very visible in the examiner's eye. So definitely practice will help you to overcome the problem. If the clinical judgment, no inappropriate investigation and treatment should be advised. And the managing patient concern already we talked about. Definitely doctor should be empathetic. And I can remember I discussed the empathy. What does empathy means in the previous session? Poor listening. Possibly in the exam it will not happen because we are giving the exam. We will be definitely attentive to the patient. But in the real life, in the chamber, it is very common not to attend the patient more. Patient is talking, we are busy with the mobile phone or busy with the laptop and other. For that, this is the criteria of a good doctor to be good listener, not poor listener. Identifying physical signs, missed important physical sign. This is a mistake. Again, find signs that are not present. Just to manage our diagnosis, to consolidate our diagnosis, we should not synthesize any sign there. Again, differentials, poor differential diagnosis, fails to consider the correct diagnosis. Please attend the word consider, not that fails to confirm correct diagnosis or fail to establish the correct diagnosis, not as such. Minimum in the differential also, you have to consider the correct diagnosis, because for the investigation, we have to consider the list of the differential diagnosis. So after the investigation, minimum we can be able to identify the diagnosis. So we will not lose the patient. For that, the word is considered. Managing patient welfare. So what we should not do, that something causes patient physical or emotional discomfort, we should not do. Or something jeopardize patient safety. During examination, many mistake, many accident can happen. We have to be aware of that. We should not give the pain to the patient. Okay. How can we give emotional discomfort to the patient? In the history, possibly I talk about that. If person is a smoker, patient develop carcinoma of the lung. We shouldn't tell in a very arrogant manner to the patient that this is the outcome of your smoking in the life. So you suffer now, not in that tone. So it can definitely knock the emotion of the patient. This is called mental harassment to the patient. We shouldn't do it. So if we know some tricks we discussed before also, we can get full mark in the patient welfare here. Differential diagnosis, unfortunately, we may not be able to do perfect one, but patient's welfare, we can get 100% mark. And this is among the seven. This is the skill where the pass mark is a little higher. So in the Royal College station, think that this is the most important skill, maintaining patient welfare. That's all. So, station 5, how to plan a good, very easy plan in the station 5. Suppose just I now have given the previous scenario to you so that you can remember what was the patient's problem. Acute, sudden, severe headache. I told you that possibilities could be subarachnoid hemorrhage. There may be some other issues also as well. It depends upon the duration. If it is a duration intermittent, you know how to approach to a patient of headache. In the book, it is written, right? Chronic headache, chronic intermittent headache, eh, very acute headache. We usually divide into three groups. From there, after talking, then the surrogate, what surrogate role will be there? In the history taking, surrogate could be a little critical to you. If you don't ask, surrogate will not tell you many things. But in the station 5, if you ask something, surrogate may tell you more than that. It will be the difference, surrogation. Because so that you can easily identify the diagnosis and jump to the examination or the investigation planning and the management planning. So it is very easy if we come to in future to, we can sit together, we will be able to make you understand. So in the history taking, this is the basic history sheet we devised from DOAMS. You have seen possibly before. So how to make very short one? Actually, we have to address each point here, but we have to squeeze it. You can remember those who attended the history and the communication, greet and meet station. Am I asked? I'm asking Dr. Adnan, please. Dr. Adnan, you, I think you possibly played the role of introduction. Can you remember how to start the talk in the history? Maybe a little longer one.
May I proceed, sir?
You just can proceed. Can you remember in the history,
Hello,
not in the station 5?
hello, hello, Mr. Joe Brown.
Okay. Hello, doctor.
I'm Dr. Adnan on duty today. I'm here to talk with you. Are you comfortable?
Yes, doctor. No problem.
Do you want to do you want to invite anyone else within our discussion?
No need, doctor.
Do you mind if I take some note?
No problem, doctor. No problem.
It will be confidential.
Thank you, doctor. Fantastic.
As I came to know from your GP letter that you are suffering from sudden severe headache.
Yes, doctor, you are right.
So, so how can I help you?
Okay, doctor. So this is the introduction part, but in the station 5, it is not applicable. It's not applicable. It's a long time. You say minimum half an hour it took about. So the station 5 only, good evening or good morning, Mr. Joe. I am Dr. Gani such and such. I came to know that you are having headache. Can you tell more about that? Very simple. Other things, cut it out. This is the strategy in the station 5. So introduction and the identification part. Now the presenting complaint already discussed about. You set the agenda and patient agreed upon. I came to know that you have having headache and other patient will say that okay doctor. That means patient agreed to talk to you about this issue. Now the history presenting complaint here. So to proceed on the symptom, any symptom we discussed before, this mnemonic can help. OPD CATS. Onset, progression, and the place. Place means location, duration, character, aggravating factor, relieving factor. Each and every symptom may not have all characteristics, but 3 or 4 should be always there. Onset, progression, duration, right? So minimum go to, suppose this headache patient, if the onset is very sudden, duration only 1 or 2, right? What is the severity? Very severe, okay, and patient might collapse or not immediately after. One possibility, you know, that the character of the headache is thunderclap headache, thunderclap in subarachnoid hemorrhage. So it's very easy. And if it is the case, maybe surrogate, maybe actor one, patient is acting, but subaccounted patient will not be active there. There may be some other cause, or there may be some other disease also. Even then, surrogate will tell you within 1 minute the information in the history related to diagnose a case. Everything within 1 minute they will tell. But it is your ability to identify. So if you identify the diagnosis, you may not go through the details, each and every part of the every points of this history of presenting complaints. Especially systemic inquiry may not be practical here. All the systemic inquiry not easily actually identifiable. Suppose the headache is there, our number one system will be nervous system. So first be busy with the nervous system, and others relevant system, if come out, then ask one or two, otherwise not. Though I have written in the systemic inquiry in the point number 9, actually this is designed for the detailed history taking station, not for the station 5. But how it is helping to us, we have to touch few information from each point, 1 2 3 4 5 6 7, including past history, drug history, others, in very open question type. I think in the meantime, you know what is the open question, how to ask. Suppose Dr. Adnan asked about that, how can I help you? This is very open question. Doctor, I have cough for 5 days. Okay, we got it. So you are now going in depth of the cough. How many, what is the onset, progression, duration, already said, and aggravating factor, relieving factor. These are the closed question. So basically, open question and closed questions are enough for the exam purpose, but sometimes we have to use probing question. So probing question already I discussed, or please you can go through my article also as a PDF form. I can provide also those who didn't get it. These are the different types of asking the question. So in this history taking, definitely I believe in the station 5, you can identify the diagnosis. Somebody raised, Dr. Islam, welcome. I didn't see you before. Do you like to ask anything? Dr. Islam, please.
Sounds sir.
Islam, please.
Yes, sir. I had a question. Should we start
Sorry, Dr. Islam, give
should
me a
we
few
start
seconds. Give
the
me a few seconds.
questioning?
Which slide will you like to
Okay,
discuss? From this slide, possibly. Sorry. Okay, carry on.
this one, history one.
Okay.
Well, in case of the history taking, should we start with open questions such as I got to know about your headache. Can you tell me more about that? Or should we start with can you tell me how it started?
No. The golden chance, the golden value always resides within the open type question. It will be very a safety setting for you also. You might forget what is wrong with the patient when you enter, especially in the second case of the station 5. I told you in the very beginning of
Okay.
today's discussion. So better to practice which will be the in the safe side for you. Don't be confused yourself. Suppose in the first case of the chest pain, the second case will be the leg edema. Suddenly you might forget. This is just reality. So better if you know the case even, this is the art of asking the question. First open question, because it will not take more time also. How can I help you? It's very, very gentle approach. How can I help you? Let the patient tell. Let the patient tell. Though you know about that, I came to know that headache and other. Even then, if you ask that, how can I help you? It will actually make the examiner pleased, because you know how to ask the question. Everywhere. Open question is the
Okay.
gold question, best question. Okay. Thank you, Dr. Islam. Anybody, please?
Yes.
Do you
Thank you,
like
sir.
to ask anything up to this? Anytime you can stop me. No problem, doctor. Those who are hearing. Again, in the second box, history must be focused. Already told before, but it should be complete. Complete means 8, 9, 10 parts should be there. Focused, complete. These are very characteristic word here. Complete means everything: social issue, impact of the impact of symptom in the daily life. It should be addressed. Idea, concern, expectation. Without these, no station you can come across. So, for example, as a chest pain patient, definitely you will ask about the details of the cardiorespiratory symptoms. So this is called the cardinal symptom of the system. So in one day, I hope that we can see together about the symptoms analysis, how to do. Smoking and the drug, because if it is a cardiac disease, smoking, drug history, what about the drug they are taking or not. Family history, you know, that premature cardiac death is a very risk factor for the myocardial infarction or ischemic heart disease of the patient in front of you. So all the relevant information, you see family history, you can get from the family history here. uh, Smoking history, you are getting from the social history here. Drug history, the drug history. Past history, previous diabetes or other disease patients suffering from or not. So these are the things. Everything you have to touch, but in a very small, concise manner, not the detailed one. Okay, very good. So this is very broader area I discussed in the station 5. History actually will be a bigger one, bigger part will covered by the history in the station 5. So now come to make an station 5 planner. So my beloved colleagues, be attentive to me. How to design a page so that it can help you, it can help your memory also, how to proceed station 5. So as much as I told you about the history and little about the examination philosophy, so suppose this is the box, the history stamps are there. I'm telling you about that how you practice in your daily history communication or the station 5. And I told about history communication before. Today I am telling about the station 5. So this is the history area all together in a small box with short hands. From there you have to choose, especially the general health query. In the general health query, disease severity resides. Suppose patient losing weight is very dangerous disease, maybe malignant disease in the elderly patient. So fever, weight loss, blood loss, even the menstrual history, pregnancy also. There are some points related with the different systems, but for the shortage of the time, we have to personalize our history taking in the station 5. So DOAMS decided or designed in such a plan for you may be suitable for you. This is our plan for you. You can make a plan own and devise by your own. You can have with you, no problem. I'm giving an example. So finally, past history, drug history, family history, social history, idea, concern, expectation. So this is the history part. And during the history taking, your general observation will be there, including general examination, so-called. So in the part of the general examination, many of you know that is something to be identified by vision only. Only look at the patient. You can identify many general examination findings. And lymph node possibly or thyroid, you have to palpate, bony tenderness you have to do. But history will guide you. Should you go for the bony tenderness? Bony tenderness may be a painful maneuver. So again, am I crossing or breaking the rule of the patient's welfare or not? This is important. So usually any tender maneuver should not be done. But bony tenderness is very important finding to diagnose the leukemia, you know, sternal tenderness. So, but what will be the technique in the exam? If you're thinking that the young patient having anemic, only 1 or 2 days, patient having fever, lymph nodes are palpable there, or you are getting the splenomegaly also, you need to have an idea of the bony tenderness. Then what will you do? It's a painful maneuver, already patient suffering a lot. So at that time, the strategy will be that, sir, I like to go for the bony tenderness. So examiner will understand that actually you are not willing to go for the bony tenderness because you are much alert about the patient's welfare. So it actually delight your performance. But if you go directly and press the sternum, patient will be responding with the pain. It is a discredit for a doctor. So many examinations are related. It is your strategy and style. How do you make your understand that, make your examiner understand that you know about this? This is the way. Sir, I like to do it. That's enough. Examiner will give you the credit. Not only in the station 5, especially you have to do it more in the station 5 because time is very short. But in the examination station, there is a lot of time, 4, 5, 6 minutes, many maneuver you have to do. So anyway, in the history, including time that you are doing for the observation, and if needed for some general examination part as well. And the basic, the systemic examination from head to toe, how can we design? Not as cardiovascular respirology. My suggestion is to make it sector wise, part of the body wise. Suppose you can start from the head up to toe. So you see that you started from the handshaking, introduction and other. So general observation is there. handshake, radial pulse, and others in the hand, the face, mouth, and ears if you think. Not that everybody's ears should be examined. Okay, face, you are looking. So neurology station, some cranial nerve lesions are there. Hands and radial pulse also will be there. But remember about the handshake in the corona events. And I believe that you are appearing the exam after a few months also. In these months, maybe the handshaking will be prohibited. But after that, again, we have to start with the handshaking. Anyway, take care of this. So the remaining part, that up to the neck, look, if relevant, you can examine. Thorax means heart, lungs, no, including breast, especially the female. So if for the cultural or other issues also, if you feel that breast should be examined, you can ask the patient, maybe patient feeling shy, or immediately you can take help from the examiner. Sir, I like to examine the breast. What examiner can tell? The breast examination revealed such and such. Finished. Examination finished. So you should not be embarrassed. Patient should not be embarrassed. It may happen especially for the young patient there. But you have to tell. If you think that breast examination is very, very important. Suppose a case of headache, we discussed in the previous class, patient have the complaint of galactorrhea, or patient is not complaining galactorrhea. For the hyperprolactinemia, there may be galactorrhea on expression. If we press the breast tissue, then the milk will come out. So this is also important finding. But in the culture may not allow us. We have to tell to the patient that I like to see the galactorrhea or not by expression. Answer will be given. So this situation is over. Accordingly, in the abdomen, inspection, palpation, percussion, auscultation, according to in the thorax also as such, the basic rules, lower limbs, mainly for the neurology and the musculoskeletal system, upper limb, neurology mainly, including musculoskeletal system, cranial nerves, musculoskeletal system, including the fundoscopy, and the sacral edema. That means you started from the upper part, that means face, mouth, neck, everything, and coming down until the foot, sacral edema. Then blood pressure, temperature already given to you, you can remember, so no need to measure. Blood pressure given, temperature given, height, weight. If you think, you can tell that, sir, I like to know about the BMI or I. But whenever you are talking about a patient in front of you, you should have an eye estimation that what could be the weight of the patient. This is enough, right? Suppose the respiratory rate as a vital sign. If you want to see patient is not having tachypnea, you can understand that patient having no respiratory embarrassment. But without touching the pulse, you cannot tell that there is bradycardia or tachycardia. For that, though this is a vital sign, 4 vital signs are there. The vital signs to be measured is the pulse and the blood pressure, respiration, and again about the temperature also, you should not measure by the thermometer, just you feel by your dorsum of the hand. When you started with the handshaking, if possible in the exam, handshaking can give you the patient febrile or not. So mainly examination required for the pulse and the blood pressure as a vital sign. And the dip the urine. Dip the urine almost in each and every case is important, especially for the abdominal case. If you don't understand or not, don't forget to tell about the dip the urine. So after this examination, it will be a better position for you that you can make a very good investigation plan. After the investigation plan, you should make a very good management plan for the patient. So overall, this is actually a structure of station 5 planner. We tell it DOAMS station 5 planner. As we devised it, you can devise by yourself, own better also, no problem. This is a very example one. So I think you understand. If you want to ask something from this page, please, you can raise your hand. On few seconds I am waiting. If anything confusing to you, because we devised it not from directly from the any book. Dr. Islam or Adnan also, do you like to ask anything from this planning? Nobody? Okay. So now I think the question will come for the time management. I'm going to now the time management for the history, examination, and other investigation and management. I can remind you that the total time given to you 8 minutes. So how to sectorize the time. So our suggestion is for the history, only for the history, preserve 2 minutes. But I have given extra 2 minutes here. This is part of the overlapping. Overlapping means the next one you see that in the examination 2 plus 2. So in the examination 2 minutes, history basically 2 minutes, but middle 2 minutes you have to overlap. Again, it is not a rigid one. If you need to talk a little more, and it may happen in the station 5 also, because history is very important in the station 5. So you have to take 3 minutes. And many examination cannot be done during history taking. But when you look at the pulse, measuring the pulse, you can look at the patient's eye, skin, pigmentation, many things, is not it? So for that, some maneuver of the examination can be done simultaneously by talking to the patient. So practice will make you competent how to do this thing. So in the meantime, 2 minutes or 3 minutes, so 1 minute overlapping and remaining 2 minutes for the examination. So overall, it can cover 6 minutes time. Then examiner will tell you 2 minutes left. I'm just giving an idea. In the 2 minutes, you will talk to the patient about the diagnosis. Your duty, you understand. Your task is, you can remember, tell the patient about diagnosis, explain the disease in a very short way, not very bigger sentence, longer sentence. So investigation planning, only I will do usually. You can remember the investigation or the communication, patient will ask you also, doctor, why you are going for this test? But in the station 5, remember, usually patient will not ask why you are going for this test because time is very short. So in the meantime, investigation, you have explained again 1 minute around or less than 1 minute, and the management plan. According to the investigation plan, you are getting the report later, but before getting the report, what is your plan today? Do you like to admit the patient today? Do you like to refer the case today? We discussed before also. So in the final question in each and every station, in the talking station, especially history communication, do you like to add anything more? Do you like to ask anything more? It will give you in very safe side, because unfortunately you couldn't ask about the concern of the patient, because in the station 5 very short, you might forget it, but specific marks and attention given in the examiner sheet. So it can save you, especially in the station 5, that, or in another way also, did I miss anything what I couldn't ask, can you tell me? In any other sentence, in any other form, you can ask the patient, but very simple form. We train our doctor that, do you like to ask anything more? Do you like to add anything more? It will save you really rather. So it will cover almost 8 minutes, and then examiner will tell you, thank you doctor, what is your diagnosis? So these are the thing we are coming now in the later two part, especially in the later 2 minutes. That means after 6 minutes, we have to be attentive much that anything missed before. Effects of condition on the patient's life. This is impact in the daily life. It is a very, very reality. You might forget because you are very busy with the diagnosis, investigation, examination. These extraordinary things you might forget. So I highlighted here effects of condition on the patient's life, functional limitation, whether they have any questions, concern, important. And these are the codes I have shown you before. This is our personal code given from the DOAMS for the management headlines until later one. So as I discussed before in one day, I can remember, but I will not tell about that. Only 3A model, just to make the patient understand your planning, explore, explain, and the second exploring. This is called 3A model. And health promotion, opportunistic health promotion. Do you smoke? Do you drink alcohol? It is actually in practice station 5 sometimes not possible. But in the history station, you can ask because the wider time is there, especially health promotion. And I explained the safety netting before also. So this is the wrapping consultation I like to say in the last 2 minutes time. If anything pending to be completed. And these are the common questions asked by the examiner almost. Your diagnosis management plan, any active problem patient having or not. If active problem, you have to admit the patient. And why this is active, examiner will ask you, or why you are planning to admit the patient. Okay. Complications are there or not. If possible, you will identify few complications, not always possible. Suppose if in the case of Raynaud's phenomena, could be that case is systemic sclerosis. So complications what could be? Lung fibrosis, bowel problem, esophageal dysmotility. So ask one question from gastroenterology, ask one question from the respirology. This is called actually focus history. Focus history. And again, if you can identify the complication by examination, better not to ask in the history. So the weapons are three: history, examination, and the investigations. These are actually broad heading three data box. If we can get the information by history, we should not go for the examination of the patient, especially in the station 5. I told you about the pulse and the blood pressure about. So ask only, that's enough. Pressure fall or pressure high up, definitely you have to measure the blood pressure. But in the examination, you cannot measure the blood pressure. For the blood pressure is given. Even then, if you want again to measure the blood pressure to see the fluctuation of the patient, record given in the morning record, you are now giving the examination. In the evening, you can ask examiner that, sir, I like to have the blood pressure right now, right now. So examiner will tell you that now the blood pressure is as such. They will not allow you for the blood pressure measurement because 2-3 minutes it will take. So these are the list, the broad heading the examiner may ask you in each administration, the broad heading. So as we are at the end, near few minutes only. Uh, uh, Regarding that case of headache, I just took a sample, not to practice today, to show you to that the how Royal College designed the scenario instruction for you, and a similar case practice recorded and downloaded in our YouTube channel. You can go through there. This is the link. If you request me now, I can copy for you. Otherwise, you can write in our group also regarding the headache practice in our DOAMS. You can go through this. Some advanced candidate has done it. May be helpful for you. So now already in between I was asked some questions. No time really to ask more questions. I think in the final part, I like to inform you that in the last few years, the most common cases in the station 5, thyroid cases, rheumatoid arthritis, transient ischemic attack, acromegaly, systemic sclerosis. So if you think that which systems are actually designed for the station 5, the thing is that the system not assessed in the station 1 and 3, right? There are 4 major systems are examined, but how to test other systems capability? So the remaining station 5 is there. Usually cases are selected from the systems of endocrinology, rheumatology, mainly, and few cases of the eyes, though it is a part of the neurology, though nervous system, and the TIA much common, especially in the station 5. Because why TIA? TIA is very important for the history exam, history station. It is important for the clinical, not clinical, in the communication station. It is important for the station 5 because anybody can surrogate over the TIA because the clinical symptom happened in the morning. Now you are presenting to the patient. So to pick up a surrogate is easier for the examiner for the Royal College. So TIA type station is very common. And in the station 5 also sometime the genuine patient may be there too, or there may be one genuine patient, one could be surrogate like TIA. Remember it. Or even acromegaly patient also, it can be surrogated by some person because there may not be coarse faces, only headache and hypertension. The patient can tell that, doctor, I have high blood pressure and I am having headache. Anybody can act, can play the role also. So we have to be ready in that manner that we may not have genuine patient in the station 5. There may be some surrogates. So about the surrogation in these online courses, with your friend, with your mentor, you can practice a lot. So everybody now, all the mentor, all the organization now designing their program as such so that you can practice with your mentor. Mentor will act as surrogate, not only for the station 5, in the station history communication all together 100% surrogation. So there is no doubt. So these are the 5 cases. Not that acromegaly will be given only one prototype. There may be in different ways. Patient may present with the vision problem only. Patient may present with the headache only. Patient may present with the hypertension only. So in many ways, these cases are presented. So don't think that it is very easy. You have to think of and practice. Other cases in the bottom part, musculoskeletal, acute medicine nowadays taking the lead because there is no station for assessing the acute medicine practice. So it is a very growing subject. So again, usually acute medicine will be of surrogation. No acute patient will be there in the examination. For that, the common cases list given to you. Fundoscopy less common nowadays. And I like to tell you that as fundoscopy is not accommodated in the current structure, there are many other limitations also current structure. And this design of Station 5 started from 2009. So now 10 years over. You already know that PACES 2020 designed before. So PACES 2020 could not be started for this corona crisis. So it is expected that it will be started in the PACES 2022. I will show you also a little. From them, I think fundoscopy can be a very common skill to be tested. So in your practice, take care of this. In the fundoscopy, these are the possible diagnoses I have shown here. So these are the main headlines of the top 5 cases and others. Even then, we have to extend our preparation. And this is our suggestion in 3 broad heading: endocrinology cases, rheumatology, dermatology, and the ophthalmology. So definitely the case will be within this thing, but presentation may be in the different way. So this is a broader list. My suggestion to my beloved colleague that try one after another to practice a Station 5. So go through some book to get some help and practice with your own group. Without group, very difficult to develop, refine your skill in each and every station of the PACES. And this is the picture, the modified one for the expected to be from PACES 2020. It was actually designed for PACES 2020 and expected to be started from 2022. Sorry, 2022 in future. We are waiting for that. So it is not that history station is not there, but history should be there in the Station 5 and Station 2 is a modification. So this is not the day to say about the detail of this one. We believe and we can assure you that whenever the PACES 2022 will be started, there will be actually no major changes, only restructuring of the station and restructuring of the timing. So we are very ready. We are much oriented to guide you in future. We hope so. So don't be busy with this much. But very often that only 2021 started the new year, and within 1 year we expect that most of you could pass. So there will be no problem for you. But few practically may appear in the exam in the 2022. So you can think of, but suggestion will be that now you be busy with the practice of the current going carousel. Within 1 or 2 months, if you modify your plan, it will be very easier to absorb this plan also in further. And this is our some video links, and anytime you have time, so you can go through these of many stations practice are there, and it will be enriched day by day also. So this is our suggestion, and thanking you again by telling up these, and we like to add today. Thank you very much. And if you now have some any comment query also, please you can raise your hand. And if you want to talk, you can talk also. Anyone? Dr. Islam, Dr. Adnan, and anybody, please. I told you that better that the station should be interactive one. If it is that I could make you understand everything, I'm very happy. But as a human, I may have something that may not be clear to you, something. If you want, you can raise your hand, please. Dr. Islam, please. Yes, welcome.
Yes, sir. Sir, I had some query about how to present the case to the examiner, because we have been discussing how to plan the case or get the history out of the patient. But how should the opening statement be, or what kind of questions do the examiners usually do?
As we are discussing about the Station 5, I think we can discuss only Station 5 today. Okay, Dr. Islam. So in the Station 5, you
Yes,
can
sir.
see that only 2
So
minutes are
even in
there.
case of Station 5,
Yeah. So actually,
yeah.
it will be a very interactive one. Not like today that I am talking much more and most of you are silent. In this Station 5, examiner will take the lead and
Okay,
help you rather. Examiner will ask
exactly.
you, what is your diagnosis? Very clean cut.
Oh,
not that present your case. It is unexpected
Okay.
in the station 5
So
because it
should
will
I
take time.
just go for the diagnosis without
Yes, yes, yes. They will ask. Don't be worried
so
that you have to tell. They will ask you what
oh,
is your diagnosis. So you will give the answer and what is your plan exactly. But in 1 minute, this is the strategy. If
okay.
you can cover many things in 1 minute, it will be glamorous for you. It is a technique to make the examiner more satisfied. How to do it? Suppose examiner ask you,
Okay.
what is your diagnosis? So it is very customary that they will ask you the second question, maybe what is your differentials? How will you investigate the case? How will you manage the case? So if intelligently, it is in customs.
Yes.
Don't take it negatively. You are asked only diagnosis, but definitely as a doctor, you are not only busy with the diagnosis. As a doctor, what is your duty? Planning of the investigation, planning of the management. So by asking one question, you complete the answer of 3 or 4 questions, mean up to the what is your management plan. Otherwise, examiner will ask you second question. You will give the second answer. It will cut more seconds, more time. So in one question, you finish your complete three or
Yes.
four question answer that this is my diagnosis. In the station 5, no need to say that evidence by. You can remember in the examination station why you are telling that this is a pulmonary fibrosis. You have to tell inspection, palpation, and other findings. But in the station 5, it is not that. You have to tell that this is the evidence that patient is having, because examiner already observing you that you have taken the history, you have examined according to the need. So they will not ask you why you are telling that this is that. Only they will ask the question if your diagnosis is wrong. Okay, Dr. Islam? Or you are not telling the prime diagnosis in your first diagnosis. Then they will ask
Okay.
you
Thank you, sir. Yes.
some maybe the confusing things are happen. So you finish your first question up to the management. So let examiner to ask you further question. This is a glamorous one. So examiner will ask you some what I say second line question. This is best strategy. Not wait for the question from the examiner, but first question they will ask you very commonly, what is your diagnosis? Okay, Islam, finish. I think no other question. Thank you very much.
Okay.
Thank the doctor.
Yes. Thank you,
And
sir.
I assure you, hope that in the coming day, I think within 1 week or few days, we will sit for very exceptional session 1. It could be about the layman term, that how to ask the question of different issue to the patient in the patient format. I think it will be a very interesting one, inviting you all together. It will be again a free session, no doubt. Thank you very much for your participation today. Best of luck.